Good morning. My name is Dr. Sakala. This is my picture. I'm from Loma Linda University School of Medicine, which is about 70 miles up the road from Pasadena here. This is a review course, which means that obviously we cannot go over everything in depth. For many of you, this is material which you already know, and it's just to kind of emphasize what is important. For some of you who may be, for instance, you've been a psychiatrist and you're moving to another state and you've got to get your step 3 and you haven't done fetal monitoring for, they didn't even have it when you had it. You may need some extra material. Now, this is a book which is available. I happen to know the author. This is a board review series, OBGYN, and is available in any bookstore. You don't need it. This is a book which just came out recently. It's High Yield OBGYN, and it's much thinner. It's much more brief. Many of you have already seen it. Again, it's available at any of the bookstores. I don't think you need it if you are, in fact, just a review, because these notes are outstanding. This is Swanson's Family Practice Review Book. This is a Kaplan publication. This one is about 2 inches thick. It is outstanding, but unless you are really anal, it isn't worth it. But if you really want to get into the nitty-gritty, it's really very good. I wrote the OBGYN section on it, so of course I think it's pretty good. But I don't think you need it. Okay, we're going to start with case number 1. We're going to start with case amenorrhea, nausea, and vomiting. And here we have our case. 20-year-old, gravida 0, para 0, comes to the office stating her last menstrual period was 2 months ago. She previously had regular menses, became sexually active a couple of months ago using a contraceptive diaphragm irregularly, so she wasn't using it very regularly. How effective is a diaphragm, do you think, in terms of contraceptive efficacy? Not as good as you'd like to see. She has nausea and vomiting. Amenorrhea, nausea and vomiting, breast tenderness. What would you like to think of? A pregnancy, quite possibly. General exam is unremarkable. Pelvic exam, anteverted uterus, 10-week size. So the uterus is enlarged. This certainly sounds like probably pregnancy. So our working diagnosis would be secondary amenorrhea, probably due to pregnancy. Now, she has nausea and vomiting. Does she have hyperemesis gravidarum? How many women who are pregnant have nausea and vomiting? It's virtually all of them. So you can't call all of them hyperemesis. Hyperemesis is where it is excessive nausea and vomiting. So we can at least look at that. So our initial diagnostic plan. How do you identify if she is pregnant? Beta-HCG. Now I'm going to tell you something which is not true. But whenever you have a female in the reproductive years, whatever the complaint, pass through your brain beta-HCG. You'll see as we go along. Pelvic pain, what you need to rule out. Ectopic pregnancy, beta-HCG. Abnormal bleeding, what you need to rule out. Threatened abortion, beta-HCG. Whatever, enlarged pelvic mass, what you need to rule out. Most likely cause of a pelvic mass in the reproductive years is a pregnant uterus. So, beta-HCG. And a urine beta-HCG is as sensitive as a serum, and it's cheaper. So they'll want you to do the cheaper stuff on the exam. Now, since we're concerned about hyperemesis, how about urine ketones? Specific gravity will tell us whether she's taking enough calories and whether or not she is dehydrated. And then let's look at her weight. Because weight, serial weights, is probably the best indicator of long-term fluid status. So the beta-HCG is positive, so we have a pregnancy. If you have a positive beta-HCG, there is functional, viable trophoblastic villi somewhere in the body. Beta-HCG is negative, you can basically rule out pregnancy because it's very sensitive. So if we have a positive beta-HCG, we know that she has trophoblastic villi someplace. Her urine ketones are trace. Is that bad? That's very common. I mean, what is the relationship between urine ketones and serum ketones? not very good. You can have high levels of urine ketones without having a ketonemia. Specific gravity is 1015. Is she dehydrated? No. Current weight? Unchanged. So she's probably not got hyperemesis. Our assessment? Probably intrauterine pregnancy. Beta HCG is positive if it is greater than 5 million international units. That's probably the threshold for a quantitative. And the urine test, as I said, is as sensitive as a serum test. Now, with nausea and vomiting, could she have a molar pregnancy? How would you identify if she had a molar pregnancy? Ultrasound. Ultrasound will show you what? Snowstorm. Remember the snowstorm? And then, with the hyperemesis, you also need to think of hyperthyroidism, which could cause that as well. So, we're going to get a pelvic ultrasound. We're going to get TSH and free T4 because your TSH is not affected by pregnancy. Your diagnosis of hyperthyroidism will be the same levels of TSH as if she wasn't pregnant. The pelvic ultrasound shows an intrauterine pregnancy, crown rump length, 10 weeks gestation, positive cardiac motion. Are you happy with that? What's a normal ultrasound look like? Gestational sac, fetal pole, cardiac motion. That's what you'd like to see. Now, if it's early in pregnancy, you'll see a yolk sac. But after 10 weeks, you won't see a yolk sac usually anymore. So this is very normal. Her TSH and free T4 are within normal limits. So this sounds like a pretty typical just early pregnancy. And this gives you an outline of what you should do in terms of pregnancy management. And I'm not going to go over this in any great detail. Pregnancy counseling, avoid alcohol, tobacco, hyperthermia. What is the safe level of alcohol use in pregnancy? What is the safe level of tobacco? So we counsel not to use tobacco or alcohol. Now the prenatal laboratory tests, and I've outlined them all over here, and I'm not going to go these in detail, but basically what they are designed to do is either, number one, prevent a problem from developing, which is primary prevention, or two, is to identify early a problem and to deal with it before it becomes a problem. That is called secondary prevention. Let's take, for example, a CBC. What is a CBC designed for? Is she anemic? Now, you're not going to prevent anything, but you identify it early. The urinalysis is designed in the urine culture. Could you have an asymptomatic urinary tract infection so you can treat it early? Blood type and atypical antibody screen. Now, that is primary prevention. We're wanting to see if she is Rh negative, and if she's Rh negative, we will give her Rh globulin at 28 weeks. You get the idea? Okay. Nutritional counseling, frequent small meals, bland foods. This is for the nausea and vomiting. All pregnant women should have 30 milligrams of elemental iron a day and folate 0.4 milligrams. We'll talk more about that later. And the return visits are every month up to 28 weeks, and then every 2 weeks up to 36 weeks, and then weekly until delivery. Why is there an increased frequency of visits as a pregnancy goes along? Because the likelihood of developing problems, particularly preterm labor, preeclampsia, gestational diabetes, will increase as the pregnancy goes along. In the first few months, there's really not that many things that can go wrong which the patient isn't aware of. For instance, how would you diagnose if there was pregnancy bleeding? The patient tells you, right? How do you diagnose gestational diabetes? There's no symptoms. See, the only way you can check that is to have them come in for a prenatal visit. How do you diagnose early hypertension? Does the patient have symptoms? Usually early hypertension has no symptoms. It's just a blood pressure check. That's why we see them more frequently as time goes by. Okay. Any questions then on normal prenatal care? Yes, sir.
You said every 4 weeks. Isn't the new thing now that they can come in any time for whatever they want? There's no specific 4-week duration.
For the exam, I would put down every 4 weeks. There has been no really good randomized prospective studies looking at the optimal frequency of prenatal care. But just by common assent over the last 50 years, monthly up to 28 weeks, and then bi-weekly up to 36 weeks, and then weekly. Any other questions? Okay. That's pretty straightforward. Our next case is going to be case number 2. Our next case is going to be first trimester bleeding. All right, a 24-year-old, gravida 1, para 0. Are you familiar what gravida and para means? You all know that. Gravida is a number of pregnancies, regardless of duration, regardless of if it was aborted, spontaneously, induced abortion, regardless of whether it was a stillbirth or a live birth. Para is a number of pregnancies that went to 20 weeks or greater. It doesn't matter whether there was 1, 2, or 3 babies. It doesn't matter if it was a stillbirth or a live birth. It's still a para 1. So G1P0 means never been pregnant before, and she hasn't gone past 20 weeks. She comes at 8 weeks presenting to the outpatient office with vaginal bleeding and minimal lower abdominal cramping times 1 day. 8 weeks, bleeding, what are you thinking of? Miscarriage, right? Or the medical term would be an abortion, either a spontaneous abortion. She has minimal lower abdominal cramping, no trauma, no nausea, vomiting, or dysuria. Why do you think we have nausea and vomiting? If she had a molar pregnancy, what's the most common symptom of molar pregnancy? First trimester bleeding. Then you add to that nausea and vomiting, then you need to wonder about, every time you have first trimester bleeding or early pregnancy bleeding, at least pass through your brain molar pregnancy. Okay, last intercourse 2 weeks ago, a febrile stable vital signs, abdomen soft and undistended, minimal suprapubic tenderness, speculum exam, small amount of dark red blood. So she has some bleeding, but it's not bright red. Cervix is closed. That's going to be important. We'll talk about that. Bimanual exam, slightly enlarged, symmetrical, non-tender uterus. What would you expect at 8 weeks? How much would the uterus be enlarged? Just slightly enlarged. Okay, this would be a pretty common finding with 8 weeks. So slightly enlarged, symmetrical, non-tender, no cervical motion tenderness. What would that be helpful to rule out? PID in pregnancy doesn't occur very often. There's something else that has cervical motion tenderness with a pregnancy. Ectopic. So any ectopic pregnancy, anytime there's early bleeding, you should think of ectopic pregnancy, you should think of molar pregnancy, along with all the other things, the threatened and so on. All right. Our differential diagnosis. Certainly threatened abortion. Hydatidiform mole, ectopic pregnancy. Those would be the biggies that I'd be concerned with. Which is the most likely, do you think, given the presentation? Most likely threatened abortion. It doesn't sound like an ectopic, no cervical motion tenderness. Let's see what we're going to do. Let's confirm that she's pregnant, urine beta HCG, get a CBC, sonogram, blood type. Urine beta HCG, one more, atypical antibody screen. Titer of 46,000. Is the titer of 46,000 appropriate for 8 weeks? Actually, what is the peak gestational age for the titer, beta HCG titer? 10 to 12 weeks. So this is not outside of the limits of normal. If you had this maybe at 22 weeks, it would be a little high. But this is pretty good, normal. CBC shows hemoglobin 12, hematocrit 37. Are you happy with that? I'm happy with that. Ultrasound shows intrauterine pregnancy, 8 weeks gestation, positive cardiac motion. Are you happy with that? It's not an ectopic pregnancy. Blood type A positive, atypical antibody screen, negative. Working diagnosis, threatened abortion. Threatened abortion is diagnosed with first trimester bleeding in the presence of a sonographically normal pregnancy and absence of cervical dilation. What's more likely than not going to happen with this pregnancy? What is the outcome? when you have threatened abortion? Most of them go fine. Most of them go fine. So, treatment plan, reassurance due to positive fetal cardiac activity. If she's 8 weeks, normal ultrasound, cervix is closed, the likelihood of losing the pregnancy is probably less than 2%. So she's probably going to do fine. Routine follow-up, call if there's worsening pain, bleeding, fever, chills, or passage of tissues. Otherwise, she's probably going to do all right. Differential diagnosis. We've got threatened abortion, and that's more likely what's going on here. Missed abortion. What's missed abortion? Pregnancy is non-viable on ultrasound. Non-viable on ultrasound. This is all in your discussion section, which is at the end of this case. A missed abortion, the cervix is closed, but there's a non-viable pregnancy. How about inevitable abortion? The key difference here is the cervix is open. Has she passed any tissue? No tissue passed. Incomplete abortion. She's passed some tissue, some still remains. And completed abortion, the cervix dilated, she passed everything, and the uterus is empty. And then think of molar pregnancy and ectopic pregnancy. How do you manage threatened abortion? We've already talked about that. Conservative management. You know, in the olden days, the patient was given DES, diethylstilbestrol. Did that change the outcome? What's the most likely cause of a first trimestral loss? Chromosomal. What can you do to change the chromosomes? Nada. So, conservative management. Missed abortion, a scheduled D&C. There's no rush, but the uterus will probably need to be emptied. Inevitable abortion, emergency D&C, because she can lose her blood volume pretty quickly. Incomplete abortion, the same thing, emergency D&C. And completed abortion is basically conservative management. Now, if you didn't confirm that she had a pregnancy intrauterine before, and you're concerned that she could have an ectopic pregnancy, then you should probably follow serial beta-HCGs. Because what would you find if she did in fact have a completed abortion? Beta-HCGs will go down. If she has an ectopic, they won't go down. Okay, our next case is pain, spotting, and missed menses. 26-year-old comes to the emergency department with sudden onset of lower abdominal pain. Sudden onset. Starting 3 hours ago, increasing in intensity. So number one, there is pain. Secondly, vaginal spotting. So she's got bleeding. Started 2 hours ago. Last menstrual period was 6 weeks ago. You got that triad. Pain, bleeding, amenorrhea. What's your assumption as far as the diagnosis? Ectopic pregnancy. That is the three criteria, the triad we talk about for ectopic pregnancy. Pain, bleeding, amenorrhea. Let's work our way through. She's been sexually active since age 17, multiple partners. What would that make you think of? PID. PID can cause adhesions. PID is the main risk factor for ectopic pregnancy. All right? Foam for contraception. How effective is foam? Not overall too good. She had an appendectomy. Why is that important? One of the differential diagnoses of pelvic pain is appendicitis. But she's had an appendectomy, so that's not going to be an issue. She's afebrile and stable. Now, the afebrile is going to be important because if she had PID, one might expect a fever. She doesn't have a fever. Vital signs are stable. Abdomen is flat with lower quadrant tenderness and rebound. Right more than the left. Would you expect with an ectopic pregnancy bilateral or unilateral pain? Unilateral pain. And that's what we've got here. Speculum exam, dark vaginal blood without cervical purulence. If there was PID, you'd expect some purulence. Cervix is closed, thick, but moderately tender to motion. So she's got cervical motion tenderness. Uterus is slightly enlarged. Would you expect an enlarged uterus with PID? No, this is consistent with ectopic. right adnexal tenderness, but no palpable masses. Differential diagnosis. Ectopic pregnancy must be number one. We've got to rule that out. Now, what are other causes of pelvic pain? PID, appendicitis, endometriosis, ovarian cyst. The most likely, however, we have is ectopic pregnancy. What is the way of ruling out or ruling in ectopic pregnancy? All right. First, we're going to get a urine beta-HCG. If that is positive, then we would get a quantitative. But a quantitative is much more expensive than a qualitative urine. If all you want to know first is yes or no, get a urine. All right. So we will first get a urine, and then a quantitative. We're going to get a vaginal ultrasound. Why a vaginal, not an abdominal ultrasound? It has much better resolution. And we want to see, is there an intrauterine gestational sac? So you can see that much earlier with a vaginal ultrasound. Blood type and RH, because if she's RH negative, we'll give her RhoGAM. Going to CBC. And again, just because she's bleeding, could she be anemic? What's the beta-HCG show? Urine test is positive. Serum is 3,500. Keep that in mind. 3,500. We'll come back to that. Vaginal ultrasound. No intrauterine pregnancy. Got that? She's O positive. CBC, hemoglobin 12, hematocrit 37. That's not a problem. What we've got now is a beta-HCG, which is over 1,500. We have a vaginal ultrasound that shows no intrauterine pregnancy. Our working diagnosis must be ectopic pregnancy. And how do you make a diagnosis of ectopic pregnancy? The presumptive diagnosis is if there is no intrauterine uterine gestational sac and the beta-HCG is over 1,500. Let me explain this. Where does beta-HCG come from? Where is it produced? Trophoblastic villi, the syncytial trophoblast. A small amount of syncytial trophoblast, a low level of beta-HCG. As the pregnancy grows, the beta-HCG is going to rise. As the pregnancy grows, at some point in the uterus, it's going to be big enough to see with ultrasound. What is the parallel beta-HCG titer for when you can see an intrauterine pregnancy? 1,500. So if you have a beta-HCG over 1,500, no intrauterine pregnancy on vaginal ultrasound, you got your diagnosis. Where is the ectopic? I don't know. The most likely place is fallopian tube, but it could be in the abdomen, it could be in the cervix, it could be in the cornal area, anywhere. But when you see no intrauterine pregnancy with transvaginal ultrasound, beta-HCG over 1,500, your working diagnosis is ectopic pregnancy. Now, our management of ectopic pregnancy could be either medical or it could be surgical. The medical management costs 1/3 that of surgical. Which will you want to then choose if you had a choice? The cheaper, right? And it's just as effective. The criteria for choosing between medical and surgical is the beta-HCG titer. If the titer is over 5,000 to 6,000, probably it's going to be so far along that it's not going to be helped by the methotrexate. If it's less than 5,000, we're going to go with methotrexate. In this particular case, what was our beta-HCG titer? 3,500, methotrexate. IV methotrexate therapy. Now, the methotrexate, what's the mechanism of methotrexate? Folic acid antagonist. It's going to destroy any rapidly growing tissue. How will you know if it has destroyed the beta? I gave it away. How would you know if it destroyed the trophoblast? You're going to get serial beta-HCG levels. You're going to get serial beta-HCG levels. And the levels should drop down to 0. And here you can see the beta-HCG titer drops down, and here we have a beta-HCG of 5, less than 5. That's the threshold. How long should it take then for the beta-HCG to become 5? 4 weeks? 8 weeks? A couple of months. You may need to follow these titers. Now, what you don't want to see is, well, this is what it's supposed to do. What if it does this? What's going on here? Your methotrexate hasn't done it because you haven't destroyed the trophoblast. So now you're either going to have to give a second dose or you're going to have to go with laparoscopy. Okay, risk factors for ectopic pregnancy. The symptoms, I should say, if it is unruptured, amenorrhea, vaginal bleeding, unilateral pain. If it is ruptured, it depends on the extent of intraperitoneal bleeding. This is all in the discussion section of the case. If you have a patient that comes in on the exam, amenorrhea, vaginal bleeding, what's the third one? Pain, tachycardia, hypotension, what's your diagnosis? Ruptured ectopic. What's your management of a ruptured ectopic? Surgical. Into the OR. And you're going to do your surgical management. Now, the signs of an unruptured ectopic: unilateral adnexal and cervical motion tenderness, no fever, enlarged uterus. The signs of a ruptured ectopic, and it depends on how much bleeding there is, how much peritoneal irritation there is. You may have minimal or you could have a lot. If you have a lot of bleeding, then you could have hypovolemia, hypotension, and tachycardia. But both of these, our basic approach is going to be beta-HCG and ultrasound. Now, if a patient comes in amenorrhea, vaginal bleeding, abdominal pain, hypotension, tachycardia, you don't have time to do a beta-HCG. You don't have time to do an ultrasound. You just head for the OR with a presumptive diagnosis. Okay. So, ruptured ectopic, urgent surgery. If you find an intrauterine pregnancy, you individualize the management. If you're unsure, you repeat the ultrasound and beta-HCG. For instance, let's say you do the beta-HCG and the titer comes back 900. The ultrasound shows no intrauterine pregnancy. Is it an ectopic? Could be. Could it be a normal pregnancy? It could be both. If she's stable, you're going to repeat the beta-HCG in 2 to 3 days. What happens to the beta-HCG in a normal pregnancy in 2 to 3 days? It doubles. So in a couple of days, it should be 1,800. All right. So if you're unsure, repeat the ultrasound. So ruptured ectopic, surgical. Intrauterine pregnancy, individualized. If you're unsure, repeat the beta-HCG and the ultrasound in 2 to 3 days. Medical management, methotrexate is a folate antagonist. The criteria would be beta-HCG less than 5 to 6,000. This is the preferred management because it's much less expensive. Surgical management, we're going to do a salpingostomy, segmental resection, or salpingectomy. Now, salpingostomy is where you open up the end of the tube and you just dissect out as much of the trophoblast as you can. This is the most likely approach because most ectopics are distal. The segmental resection is if it is a proximal pregnancy in the tube and you've already destroyed that tube, and so we're going to take out that part. What if she had a previous tubal ligation, she had a failed tubal ligation and now has an ectopic? What does she want you to do? Take the tube out, salpingectomy. And that's going to be 3 times more expensive than the methotrexate. And we're going to follow up with serial beta-HCG titers if there's a salpingostomy because you didn't take out all of the tube. You could have some residual which is left in there. And we want to give Rogam if she is Rh negative. And here you can see the 2 kinds of procedures. The salpingostomy is where you open up the distal tube, dissect out as much as you can, but you don't know if you've got everything out. If you do a segmental resection, you know you took all the trophoblast out, so you don't need to do the beta-HCG titers on that one. Okay, our next case is post-abortion fever and tender uterus. Our next case is post-abortion fever, tender uterus. 17-year-old comes to the outpatient clinic with sudden onset of increasing abdominal pain, fever, lethargy, weakness, vaginal bleeding. 2 days ago, she underwent a suction DNC abortion at 8 weeks gestation. That's an extremely important part of the history. She underwent an abortion at 8 weeks gestation. No nausea and vomiting, regular bowel function, but she has 103 temperature, pulse 100, blood pressure 90/60. Is that too low for a 17-year-old? That's probably... Hey, my blood pressure runs about 100/60. But I'm dying, you see. No, this is appropriate for a young person. But I would be watching, obviously. Respiration's 30. Now, that's troublesome. What's normal respirations? 18 to 20, something around there. All right. Extremities cold and diaphoretic. What does that suggest? Peripheral vasoconstriction. Lungs clear. Pulses are weak. I don't like this. Regular rate rhythm. Abdomen flat, soft, tender in the mid to lower abdomen. Active bowel sounds. No guarding or rebound. Now that would suggest that she doesn't have peritoneal involvement. The pelvic exam, the uterus is 6 weeks size, exquisitely tender. An exquisitely tender uterus without peritoneal signs suggests to you that you have an infection of the uterus. An endomyometritis. Cervix is closed with thick mucopurulent discharge present. Now this is not a subtle case. What's the differential diagnosis? Septic abortion must be number one. Must be number one. But are there other causes of fever and pain? Yes. PID, appendicitis, endometriosis, not so much fever, but can certainly cause pain. Ovarian cyst, which is ruptured, could cause pain. But clearly, our number one diagnosis must be septic abortion. She got infected from the abortion. Now, this is unusual, but it certainly can happen. So, quantitative beta-HCG, CBC with differential, arterial blood gases. She's got a tachypnea. We've got to make sure that she's stable pulmonary-wise. The quantitative beta-HCG is 1800. Would that be appropriate? How long, well, I already showed you that picture, how long it takes for beta-HCG to go down. She had the pregnancy termination just a couple of days ago, so that's certainly appropriate. CBC, white count is 21,000. Would that be consistent with an infection? You betcha. Her hemoglobin hematocrit, 12.5 and 39. Perhaps a little hemoconcentration. Arterial blood gases are normal. All right. So, our assessment would be retained products of conception. And those can serve as a nidus for infection. And what's the most likely cause of or source of the bacteria for a post-abortive infection? Normal genital flora. Normal genital flora. What's normal genital flora? Anaerobes, aerobes, gram-positives, gram-negatives. It's everything. Further diagnostic plan. Vaginal ultrasound. We want to see, is there anything left in the uterus? Blood, urine, cervical cultures. The transvaginal ultrasound shows residual intrauterine debris. So it was an incomplete abortion which got infected. An incomplete abortion, probably. No adnexal masses. Blood, urine, cervical cultures obtained, but those won't be back until later on. But does she sound like she could be septic? Sure does. You know, her tachypnea, her high fever, her pulses are weak, her skin is cold and a little clammy. Post-abortal endoperimetritis. Recent induced abortion, fever with a tender uterus, retained intrauterine debris. That's the only thing that you can think of at this point. What's the management? We want to empty the uterus. So we're going to do another suction D&C. But before we do that, we want to get antibiotics on board. So we're going to use broad-spectrum IV antibiotics to cover polymicrobial. Gram-positives, gram-negatives, aerobes, anaerobes. So what we're going to use here is triple antibiotics. It will cover everything except viruses and fungi. Ampicillin, gentamicin, clindamycin. And we're going to watch her carefully. Now, if she is really sick, I'm going to put her in the ICU. We're going to follow very closely with fluid management and so on. Okay, how does a endomyometritis start? Initially, you have an endometritis, which starts in the endometrium. If that is not adequately treated, it will proceed through the lymphatics and will become an endomyometritis. And if that isn't adequately treated, it will proceed further through the lymphatics and become an endomyoperimetritis. And from then on, you can get a peritonitis and all kinds of different things. Okay. Our next case is pregnancy with atypical antibodies. Our next case is pregnancy with atypical antibodies. Here's our case. 31-year-old, gravida 2, para 1, comes to the outpatient office for her first prenatal visit at 12 weeks by dates. What's the average or usual gestational age patients present for prenatal care? This is pretty common, 8 to 12 weeks. Her prenatal laboratory panel reveals a blood type of O negative. What percentage of Caucasian population in the United States are Rh negative? 15%. 15%. What percentage of mainland Chinese are Rh negative? They don't even do Rh on the prenatal panel there because it's very seldom. In the United States, 15%. Now, here's where the significant issue comes in. Her atypical antibody titer is positive. What's atypical antibody titer mean? She has antibodies against red blood cell antigens that should not be there. Can we assume that these are Rh negative antibodies? No. There's a whole host of antibodies other than the big D. She has been married for 10 years to the same husband who is the father of both her pregnancies. His blood type is AB positive. She's O negative. Their first child is B positive. Does this make sense that he could be the father of this child? Yes, good. All right. Listen, geneticists say that 10% of the time, the man who the woman says is the father of her baby isn't. She knows it, but she's not going to tell you. So you always need to kind of keep that in the back of your brain, right? Okay, isoimmunization. There's only one differential diagnosis, isoimmunization. She's got atypical antibodies. These are antibodies against either the big D antigen, which is the antigen for Rh negative most of the time, or some other red blood cell antigen. So we know she's got isoimmunization. The first step we must do is to type the antibody. What is the antibody? It's anti-Cal. What percentage of the Caucasian population in the United States is Cal negative? 85%. Only 15% are positive. So it's just the opposite. So there's a good chance that her husband is Cal negative. All right. So we've got anti-Cal antibodies which are associated with severe hemolytic disease of the newborn, HDN. Have you heard this? Cal kills, Duffy dies, Lewis lives. Anti-Cal antibodies are not good. Anti-Duffy antibodies are not good. Anti-Lewis antibodies don't cause hemolysis. So it's important to find out, are they associated with hemolytic disease or are they not? Now, in order for the fetus to be at risk, all 5 of these prerequisites must be present. Number 1, the mom must be antigen negative, and we know she is. Secondly, the dad must be antigen positive. If the dad is antigen negative and the mom is antigen negative, what's the fetus going to be? Negative, and there's no problem, because unless the antigens are present on the baby's red blood cells, the antibodies won't do any harm. Are you following me on that? So mom must be negative, dad must be positive, and there must be atypical antibodies present. 4, those antibodies must be associated with hemolytic disease of the newborn. And 5, the antibody titer should be 1 to 8 or greater. In other words, that there's a lot of antibodies around. So, in terms of our diagnostic plan here, we want to determine if the father of the baby is Cal positive or is he Cal negative. And we're going to determine the anti-Cal antibody titer. What do we find? Darn it! Father's Cal positive. Could the baby be positive now? Yes, but if the father is heterozygous, could be either positive or negative. We don't know, right? But we know there's a risk. What is the anti-Cal antibody titer? 1 to 2. Is this high? This is low. This is low. So this is good at this point, at least. The idea here is that you can get a negative test by diluting it 2 times, which means that the antibodies which are present to begin with must be so low that they dilute out early. And when they're so low, we're not concerned about a significant risk to the fetus. So, what's our management? We're going to follow the monthly anti-Cal titers as long as the level is less than 1 to 8. No need to do anything further. If the titer should rise above 1 to 8, now we need to identify, is the fetus anemic? And there's 2 ways we can identify if the fetus is anemic. One is by amniocentesis, looking at amniotic fluid bilirubin. Are you with me? The optical density, 450 nanometers. Okay. Or we can do a percutaneous umbilical blood sampling where we actually take fetal blood and look to see what the fetal hematocrit is. If the father of the baby was Cal antigen negative, end of story. You don't need to do anything further because there is no risk to the fetus because the fetus would have to be negative as well. Okay, let me just summarize what we've already said. Don't write all this down unless you're really anal. First question, is the antibody associated with hemolytic disease? If it isn't associated with hemolytic disease, management is conservative because there's no risk. Anti-Lewis antibody, for example. If the antibody is associated with hemolytic disease, the next question is the father of the baby positive for the antigen? If the father of the baby is negative, the fetus must also be negative, no risk. If the antibody is associated with hemolytic disease, the father of the baby is positive for the antigen, next question, how high is the titer? If it's less than 1 to 8, repeat the titer monthly, as long as it stays there, no problem. If it is over 1 to 8, then we need to find out if the fetus is anemic. How do you find that out? Either a percutaneous umbilical blood sample or an amniocentesis. Okay, that's a quick run-through. Did it stretch your brain a little bit? Any questions on this? Are you just yawning at the back there? Okay. Let's just talk very briefly about RhoGAM, prevention of isoimmunization. The mechanism of RhoGAM is passive anti-D antibodies, which are put into the mother's body, and if they find any red blood cells with a D antigen on it, they will lyse those cells before her lymphocytes get activated to produce antibodies. When do we give RhoGAM? Routinely, we will give it in the United States at 28 weeks to all Rh negative moms. We don't know the fetus may be negative or positive, but since we don't know, we'll go ahead and give it anyway. And then after delivery, we'll check the baby's blood type. If the baby's negative, then you don't need to give it. If it's positive, then we give a second dose. And the reason for giving it at 28 weeks is to prevent the 2% of women who could get isoimmunized from fetal maternal bleed that normally occurs prior to delivery. Times for special administration are post-chorionic villus sampling, post-amnio, D&C, ectopic pregnancy, abruptio placenta, placenta previa, we'll talk about that later. Any time there is an increased risk of fetal placental blood crossing into the mother's circulation, we want to make sure that she doesn't have the antibodies produced from her lymphocytes. Okay. And I think that should do it for there. Any questions on this? Question?
We give come at 28 weeks if the dad RH positive.
Okay. The question was, you would give the RH immune globulin at 28 weeks to an RH negative mother if the dad was RH positive. That's correct. If the dad was RH negative, then he doesn't really need it. Now, what I typically do is this is what I say.
What if he was heterozygous, RH negative?
If he was heterozygous, then you'd give it, because you wouldn't know what the fetus is. But let's say that mom is negative and the father was negative. I'm sorry, the husband was negative. What I say is, okay, if you are negative and if he is negative, the baby is going to be negative and there isn't going to be a problem. Do you want to get it anyway? And if she says yes, no questions asked. Okay, last question.
Yeah, I have a question about the medical ethics. When the father of the baby is not the husband of the patient, so but if there is a complication and he wanted to know, are you going to explain to him about that you are not the father?
The question is, if the father of the baby is not the patient's husband and she doesn't want him to know, but he asks, who is your patient? The woman is your patient. And confidentiality is really important, and I think legally and ethically as well. And I don't think you have any business revealing information about her to somebody else without her consent. I can tell you some very interesting stories of cases of confidentiality. Okay, we need to take a 10-minute break, and we'll start back in 10 minutes.
Will we check?
Okay, our next case is elevated maternal serum alpha-fetoprotein on a triple marker screen. 30-year-old prima gravida comes to the outpatient clinic at 17 weeks by dates. She recently underwent a triple marker screen. When is a triple marker screen performed? 15 to 20 weeks in California. So this is the appropriate time. The triple marker screen showed a maternal serum alpha-fetoprotein of 3.0 MOM. I'll just tell you that's high. The upper limits of normal is about 2.5. On exam, her uterus is at her umbilicus. Now, she's 17 weeks by dates. Uterus is at the umbilicus. What would the gestational age by exam be at the umbilicus? 20 weeks. What would you be thinking, possibly? Gestational age is more advanced, and maybe that explains why she has a high AFP. Fetal heart tones are present at 155 per minute by Doppler stethoscope, so we know that we've got at least a fetus in there. Could there be two fetuses? Could two fetuses explain a high AFP? Sure they could. All right, so differential diagnosis, more advanced gestation. In other words, gestational age error. That would certainly be. What is the likelihood of twins? What percentage of pregnancies are twins? 1%. What is the likelihood of having a gestational age error? Oh, much more than 1%. So that certainly could be the case. Neural tube defect. What is the prevalence of fetal anomalies? What percent? 2%. I mean, not very high. And neural tube defects is even less than that. Multiple gestation, we said, is 1% of the time. Ventral wall defects, such as gastroschisis, omphalocele, how often does that occur? Not very often. Fetal demise could cause elevated AFP, but we have fetal heart tones, so at least it's not a fetal demise. Congenital nephrosis, kidney disease of the baby. Placental bleeding, we have no evidence of that. Polyhydramnios. Now, the most, or a gestational age error would be the most likely. How are we going to find out if there's a gestational age error? Ultrasound. Let me tell you another thing. any case you have on the exam on a pregnant woman, pass through your brain ultrasound. If there is bleeding, first trimester, late pregnancy, you need to have an ultrasound. Is there a viable pregnancy? Is there a placenta previa? If you have uterus larger than dates, next step in management, ultrasound. Uterus smaller than dates, ultrasound. If you want to rule out multiple pregnancy, if you want to rule out or identify molar pregnancy, if you want to find out if there's oligohydramnios, if there's polyhydramnios, anyway, you get the idea. Ultrasound is very helpful. So we're certainly going to get an obstetrical ultrasound. Here's what it shows. A single fetus with biparietal diameter, this is from one side of the head to the other, head circumference, abdominal circumference, femur length, consistent with dates. So it's not a dating error. Fetal anatomy is normal, so we don't have all of those things that we talked about, neural tube defect, renal problems, at least that we could see by ultrasound. And amniotic fluid volume is normal. It's an unexplained elevated. No evidence of dating error. Could you still have a neural tube defect even though you don't see it on ultrasound? Yes, you could. So we're going to do an amniocentesis looking for amniotic fluid AFP. The maternal serum AFP has a high rate of false positives. But if you have an elevated amniotic fluid AFP, that is far lower level. It's much more accurate. The AFP in the amniotic fluid has higher specificity than the maternal serum AFP. So, we're going to do genetic counseling, and we're going to do an ultrasound-guided amniocentesis. So we do the genetic counseling, explain to the patient what's going to be done, what the things that you can know for sure, what are the limitations, the risks versus the benefits. And what do you find on amniocentesis? The amniotic fluid AFP and amniotic fluid ACHE. What's ACHE? Acetylcholinesterase. They are both within normal limits. Fetal karyotype is normal female. What's the point of the acetylcholinesterase? It is a very specific test in amniotic fluid for open neural tube defect. If you had, for instance, ventral wall defect, the AFP, the amniotic fluid AFP would be elevated, but the acetylcholinesterase would be normal. But if you have an open neural tube defect, both the amniotic fluid AFP and the amniotic fluid acetylcholinesterase will be elevated. So in this case, it's all normal. Management, routine prenatal care. So this was one of those where we probably generated unnecessarily anxiety in the mother, and it was a false positive. Now, obviously, if you found a neural tube defect or other problems, then you would counsel her, and I think we have a case coming up about that. So the specific concerns with the AFP are what we talked about, neural tube defect, ventral wall defects, all of those sorts of things. The AFP is synthesized by the fetal yolk sac, the GI tract, and the liver. It is a major serum glycoprotein of the embryo and early fetus. The source of the amniotic fluid AFP is fetal urine. Baby urinates, and the AFP comes into the amniotic fluid through the fetal urine. The AFP levels are drawn between 15, actually this should probably be 15 to 20 weeks, but it is a gestational age specific test. You've got to know gestational age because the values will vary depending on gestational age. You can see here AFP goes up. So a normal value at 15 weeks would not be a normal value at 18 weeks. Let's say we do an ultrasound. We do an AFP level, and it comes back right there. This is way too high. Next step in management, ultrasound. It shows that the gestational age is actually 19 weeks. So we recalculate what was apparently abnormal here, turns out to be okay. So the ultrasound corrected, and now it's no longer elevated. You see where we're coming from? The ultrasound is going to be very helpful in identifying is this appropriate or not. The maternal serum alpha fetoprotein is appropriate for 19 weeks, but not for 15 weeks. The same way around, if you have an AFP level and it is just above 30, and the patient thinks that she is 19 weeks, that's too low. We do an ultrasound and we find out her true gestational age is 15 weeks, and this is okay. So, the gestational age is very important here. Okay, any questions on this? Okay. Next case is number 7. The next case is advanced maternal age, not American Medical Association. Mom has seizure disorder and requests prenatal diagnosis. So here we have the case. 35-year-old multigravida at 16 weeks comes to the outpatient clinic for a routine prenatal visit. Her gestational age is confirmed by 10-week ultrasound. How accurate is gestational age by 10-week ultrasound? Plus or minus 5 days. Very helpful. From 12 to 18 weeks is plus or minus 7 days. From 18 to 24 weeks is plus or minus 10 days. From 24 to 28 weeks is plus or minus 14 days. As the gestational age with ultrasound was done gets further and further, the less accurate becomes the gestational dating. But at 10 weeks, very helpful. Okay, she has a 15-year history of idiopathic seizure disorder, successfully controlled with valproic acid. Are you concerned about valproic acid? Yes. What are you concerned with? Neural tube defects. Thank you very much. A distant relative and a friend have delivered children with Down syndrome. She's 35. They conceived in their early 40s. She's worried about her own risk. She wants to avoid an invasive prenatal diagnostic procedure such as amniocentesis. General physical exam is unremarkable. Uterine size is midway between the symphysis and the umbilicus. 16 weeks, midway. Is that all right? Yeah, that's okay. So, our initial diagnostic plan is a triple marker screen. And I put this X for expanded AFP. See, historically, we started out doing AFP. Then we expanded it to add other markers, and that X stands for the expanded. Now there is actually probably going to come in a quadruple marker. But currently, it's a triple marker. And let's get a valproic acid level to see if she is in the therapeutic range as far as seizure control. What do we find? MSAFP is low, estriol is low, beta-HCG is high. What does this pattern suggest? Trisomy 21. Don't like it. How about valproic acid? Within normal limits, so that's okay. Does this mean that the baby has Down syndrome? This is a screening test only. It's not a definitive test. What's the definitive test? Amniocentesis and doing a karyotype. So, assessment, increased risk for Down syndrome due to AMA and the triple marker screen results. And she's at increased risk for neural tube defects due to valproic acid. So with both of these, an amnio would be helpful. Now this shows what happens with pregnancy with the AFP, with the estriol, and with the HCG. And I just want you to see these are not level values. They change. So they are gestational age specific. So we've got to know gestational age because it can make a difference. All right. We're going to do genetic counseling. We're going to do a genetic ultrasound and ultrasound-guided amniocentesis. Genetic counseling is performed. Genetic ultrasound. The genetic ultrasound, that term comes from there are specific ultrasound anatomic markers which are associated with aneuploidy. What's aneuploidy? Anything other than 46 XX or XY. So it could be missing chromosomes, it could be additional chromosomes, or it could be mixed up chromosomes. And what we find is a single fetus, size equal dates, however, thick nuchal skin fold, bilateral choroid plexus cysts in the brain, bilateral hydronephrosis. Now, neither of these in themselves indicate a chromosomal problem, but they are suggestive, and the more that you get together, the more concerned you are. And the amnio will give you the definitive diagnosis. Normal AFP, but 47XY plus 21. This is the genetic shorthand for Down syndrome. So she has a Down syndrome baby. Now what are we going to do? Trisomy 21. The amniocentesis karyotype is like 99.9% accurate. Very, very accurate. The management here is going to be counseling. You explain to the patient, here's what you've got. What does Down syndrome mean? What's going to be the outcome of babies with Down syndrome? What other problems do they have? Such as endocardial cushion defects, such as, just a lot of different things. And our options are to continue the pregnancy, perform the D&E, which would be to just deliver or abort the pregnancy surgically, or induce labor with vaginal prostaglandin E2. Which of these do you think she should do? It doesn't matter. Your feelings about this do not matter, and you better not let her know what your feelings are, because you could subtly coerce her into doing what you want her to do, and that's inappropriate because she has to live with the consequences. For some people, they would elect to continue the pregnancy, and that's a reasonable approach. Others would elect to terminate the pregnancy, and if they want to do that, that's their approach too. And you should just enhance their information base and allow them to come to a conclusion. And then maintain anticonvulsant therapeutic levels. But this concept of autonomy and having the patient make the decision rather than you telling them. And in some countries of the world, the doctor says, this is what you're going to do. Depends if it's South America or if it's in Russia or wherever it is. Don't do that in the United States. Okay, chromosomal anomalies by maternal age. And you can see here's maternal age. This is in your notes. Down syndrome risk, you can see at age 20, it's 1 in 1,600. By age 35, it's 1 in 365. Is that high? If you went to Las Vegas and your chances of winning were 364 out of 365, that's pretty good. But it's kind of like looking at it, is the glass half full or half empty? Some people would say that's far too high. We arbitrarily say that age 35 is when we will offer amniocentesis. So in her case, she didn't need to go through the triple marker screen. In the United States, we would even give her the offering, would you like to have an amnio without the triple marker screen? Now, where does most of the trisomy 21s come from? They come from a non-disjunction. You see, the primary gonadocyte has 2 chromosomes, has a pair. And at the time of meiosis, usually one of them is sent off in the polar body. If there is sticky chromosomes and it doesn't go, there's 2 left. You come along with the sperm, which gives a third, and you have a trisomy. Most of the advanced maternal age trisomies are non-disjunction.
If a younger patient asks for an amnio,
if a younger patient asks for an amnio, there are amniocentesis done for what is called maternal anxiety. But see, the problem is amniocentesis has a 0.5% pregnancy loss rate. You don't want the diagnosis to be more hazardous than the risk of the disease. And if you're going to lose more pregnancies because of the amnio, so most insurances would not even pay for it. But I'll tell you who gets a lot of amnios for anxiety. women physicians because they're, hyper. This is just to show you on the anticonvulsants what the FDA category is. Many, if not most, of the anticonvulsants are category D. What does that mean? Unsafe. We know it's unsafe, but we choose to use it anyway because the risk of not using it to the mother is worse. So we take that risk. But many of them are category D. In terms of management of epilepsy in pregnancy, the anticonvulsants will decrease folate absorption, so they need to have folate supplementation. Because of the increased risk of anomalies, we want to offer a triple marker screen, the expanded AFP, and ultrasound, the genetic ultrasound. Ideally, she will be on one agent, monotherapy, not multiple agents, because the more anticonvulsants she's on, the higher the risk of fetal anomalies. And then monitor medication levels, because she will probably need to have increased dose as the pregnancy continues. Okay, any questions on this one? Yes?
This is not a clarification. Is a D&C and a D&E, are they different?
Okay, a D&C is where you have a suction curette and you aspirate. Early pregnancies, you can do that. But once the fetus gets too big, say after 14 weeks, you can't aspirate it. You have to reach in and you pull out piece by piece. That's a D&E. So that's the difference between a D&C and a D&E. After 20 weeks, it becomes just technically, you can't be pulling off arms and legs and things like that. All right. Next case. Pregnancy with increased diabetes screening test. The next case is pregnancy with elevated diabetes screening test. Okay, 32-year-old multigravida, 29 weeks gestation, comes to the outpatient clinic for a routine prenatal visit. A 1 hour, 50-gram glucose load screening for GDM came back at 175. What's normal upper limits? 140. She's 5'4", weighs 180 pounds. Is she overweight, underweight, or appropriate ideal weight? Overweight. Pregnancy weight gain up to 29 weeks was 25 pounds. She's probably going to gain another pound each week, so she's looking at 35-pound weight gain. Her previous baby weighed 4,200 grams. Is that a little baby or? That's a big baby. At 29 weeks, her fundal height is 33. So we have a lady of average height, but high body mass index, who has a high glucose screen, who had a previous macrosomic baby, who has a fundus that is large for dates. What are you concerned with? GDM, gestational diabetes. What else are you concerned with? Macrosomia and possible shoulder dystocia. Differential diagnosis. Gestational diabetes, but false positive diabetic screening test. What percentage of women who have a positive diabetic screening test end up with gestational diabetes? 15%. What percent of patients who have gestational diabetes require insulin? 15%. So the most likely thing is if you have an elevated glucose screen, it's a false positive. However, how are we going to find out if it's false positive or true positive? 3-hour, 100-gram oral glucose tolerance test. And we do that fasting, and then you do a first test, then you give 100 grams of glucose, and then do a 1 hour, 2 hour, 3 hour. And on the step 3 exam, they give you normal values, so you don't need to memorize these. But I'm just telling you, she has 2 which are elevated. In order to make a diagnosis of gestational diabetes, you need to have 2 or more values elevated. So she's got it. So the assessment is gestational diabetes. She's got gestational diabetes. What are the symptoms of gestational diabetes? None. It's a chemical diagnosis. Okay, what are we going to do? Educate the patient regarding a diabetic diet. Educate the patient regarding the importance to the fetus of pregnancy glucose control to try to avoid big babies, hypoglycemia, lots of other things we'll talk about. The key management is home blood glucose monitoring. She does her own checks at home, keeps a record of those, brings them in, and then we see how is she doing. Weekly visits to make sure that her glucose values are okay, and monthly ultrasounds looking for macrosomia. Okay, the classification of diabetes in pregnancy is either GDM, which is diagnosed in pregnancy from insulin resistance, and we typically diagnose this after 20 weeks. Why does it take until after 20 weeks? What is the mechanism of GDM? HPL, human placental lactogen. The levels aren't high enough to antagonize insulin. But after 20 weeks, 24 weeks, they are. So insulin resistance. Then there's type 1 diabetes. You're familiar with that. Ketosis, prone, juvenile onset. And then type 2 diabetes, which is adult onset, insulin resistant. So which of these are more like gestational diabetes, type 1 or type 2? Type 2. The likelihood of a woman developing type 2 diabetes is increased if during her pregnancy she had GDM. So there's an increased risk of that developing. The mechanism of insulin resistance in GDM, as I mentioned, is human placental lactogen. Okay, 3 weeks after a trial of diet, at 32 weeks, home blood glucose monitoring records show a mean fasting blood sugar of 105. What are the values that we look for? Our target values. Fasting blood sugar less than 90, 1 hour post-prandial, post-meal less than 140. That's what we're looking for. And what are we finding here? Her fastings are 105. Too high. Post-breakfast is over 140. It's 150. Post-lunch, 145. Post-dinner, 160. So all of her mean values are above the target range. At 32 weeks, she has a fundal height of 37. That could be either polyhydramnios or big baby. Ultrasound shows a single male fetus in cephalic presentation, estimated fetal weight of 90 percentile of expected. So she's got a macrosomic baby. I don't like this. We're heading in the wrong direction. Fetal breathing, gross body movement, and extremity tone are noted on ultrasound along with AFI of 16. What have we just done here? Fetal breathing, gross body movement assessment, extremity tone, amniotic fluid. What do we call this? Biophysical profile. There's 5 components. These are 4 of them. The last one, which we haven't done yet, is NST, non-stress test. So, are we happy that this baby is doing okay in the uterus? Yeah, looks good. Normal amniotic fluid is between 5 and 25. 5 to 8 is borderline. So, we've got gestational diabetes, failed diet therapy, fetal macrosomia. Where are we going to go with this? Initiate outpatient insulin. Why don't we use the hypoglycemic oral agents? We're concerned about crossing the placenta causing fetal hypoglycemia. So we're going to use insulin. And because she's got macrosomia and she's on insulin, there is an increased risk of fetal compromise. So we're going to do fetal surveillance, NSTs, amniotic fluid index, biophysical profile, twice weekly. So, in summary, we screen all patients at 24 to 28 weeks with a 1 hour 50-gram glucose screen. If it is less than 140, gestational diabetes is ruled out. If 2 or more values are elevated, then it goes to gestational diabetes. If less than 2 are abnormal, gestational diabetes is ruled out. If 15% of patients will have a positive glucose screen, and of those 15% will have gestational diabetes, what is the prevalence of gestational diabetes? What's 15% of 15%? 2 to 3%, 2.25%. And that's what we have. Diabetes in pregnancy is about 2 to 3%. So here we are down here now. What's the next step? Once you've made the diagnosis of gestational diabetes, what are home blood glucose values? If the values are not within the target range, next step in management, insulin. And then we're going to start fetal testing. And then we're going to look to see if the fetus is macrosomic. And if the fetus is macrosomic, we're going to also do testing to make sure baby is okay. Okay, 6 weeks later in the maternity unit, she presents in active labor, 38 weeks, spontaneous rupture of membranes, but the first stage of labor was protracted and required oxytocin augmentation. I don't like this. Dysfunctional labor. She got to complete dilation. The second stage was also prolonged. Couldn't push the baby out. And somebody who wasn't very smart used the vacuum. I wouldn't use the vacuum on a patient with no gestational diabetes, macrosomia, and prolonged second stage. But they did. And they got the head to come out. However, delivery was complicated by severe shoulder dystocia that was relieved by the McRoberts maneuver. I'll show you what that is in suprapubic pressure. The infant weighed 4,600 grams and now can't move its upper extremity well. What's going on? Here's shoulder dystocia. Here's what happens, is the anterior shoulder gets hung up underneath the pubic symphysis. The management is to flex the mother's thighs, move the thighs back. We call this the McRoberts maneuver. And what that does, it tilts the pelvis, gives you more functional room. Then you want to do suprapubic pressure and try to dislodge that shoulder. Does it come out? Doesn't come out. Now what are you going to do? You put your hand on the back and try to rotate the shoulders so it goes oblique rather than anterior-posterior. Does that work? This is sometimes called the corkscrew maneuver or the Woods maneuver. Didn't work. Now what? You reach in and try to get the posterior arm. Lots of room in here, right? It's tough. You're trying to feel, where is the extremity? You can fracture things. Not very good. So you grasp the hand, bring the hand out, so you have the posterior arm is delivered. Then you rotate the baby this way. And so the posterior becomes anterior. Not good. Let's x-ray the baby's arms. X-rays are normal. Thank you, Lord. So macrosomic infant, GDM, neonatal plexus, brachial plexus injury. What happens to these most of the time? They usually resolve on their own, fortunately. Now, this big baby is at risk for a lot of other things. And you should know that, and maybe the pediatrician will go over this with you. Hypoglycemia, hypocalcemia, polycythemia, hyperbilirubinemia, respiratory distress syndrome. Watch for postpartum hemorrhage due to uterine atony from overdistension. This uterus won't want to contract, and so she can have a lot of bleeding. Monitor maternal postpartum glucose to determine if she has persistent need for insulin. Maybe she has new type 2 diabetes that was diagnosed during the pregnancy. And if it was gestational diabetes, let's make sure that the blood sugars go back to normal, and the screening for non-pregnancy diabetes is 2 fasting blood sugars. Okay, neonatal problems. I already alluded to that. Hypoglycemia, hypocalcemia, polycythemia, hyperbilirubinemia, respiratory distress syndrome. This is all in your notes, in the discussion. But what I want you to remember is we have a big baby, but it is immature parathyroid, immature liver, immature surfactant. These big babies may not be mature. They have delayed maturity. And that's what causes some of the problems with these babies. A 31-year-old Multipra comes to the outpatient clinic for routine prenatal visit at 32 weeks by dates confirmed by first trimester ultrasound. You think these dates are reliable? Absolutely. First trimester ultrasound. She has chronic hypertension managed by methyldopa. Stick this someplace in your hard disk. If you're going to use antihypertensives and medication in pregnancy, the one of choice would be alpha-methyldopa. Not because it's the best and the most effective, but it's got a proven track record in safety with pregnancy. Now, what normally happens to blood pressure in pregnancy? Goes down. So chronic hypertensive patients, the blood pressure will go down. Many of those with mild hypertension, you can take them off medications. But if you've got to use them, this is what we would use, is alpha-methyl-dopa. Now, she's 32 weeks, but she's only got 10-pound weight gain. Is that appropriate, do you think, for 32 weeks? See, pregnancy weight gain is usually 5 to 8 pounds up to 20 weeks, and then a pound per week thereafter. So she should weigh somewhere between 20 and 25 pounds additional. So she's got low weight gain. She admits to cigarette smoking, a pack a day. What are the medical benefits of smoking? I'll tell you what is interesting. There is lower rates of preeclampsia. Did you know that? But overall mortality is decreased. Is increased. So it's not a good thing. So she's got chronic hypertension, low weight gain, cigarette smoking. Are we setting ourselves up for IUGR here? Appetite is poor lately. No nausea and vomiting or diarrhea. Fetal movements are present. Blood pressure 140/90. That's okay for chronic hypertension. Normal vital signs, but fundus 28 centimeters. What should be the fundal height at 32 weeks? The fundal height in weeks should approximate the fundal height in centimeters. 22 weeks, 22 centimeters. 26 weeks, 26 centimeters. 30, you get the idea. Now there is some variation. You can see the arrows here. Plus or minus 3. But this is more than that. She's 32 weeks and she's 28 centimeters. So that's clearly outside of the normal range. So our differential diagnosis, gestational age, dating error, we know that's not the case because we've got an early ultrasound. Fetal demise, that's not present because we heard fetal heart tones. IUGR, that's the most likely one that we've got here. Oligohydramnios could also be present. Now, we used to say intrauterine growth retardation. Are these babies retarded?
No.
They're not retarded. So a better term is intrauterine growth restriction, and that's what we use. So, how are you going to find out if this baby is IUGR? Ultrasound. What do we find on ultrasound? A single fetus, size 29 weeks. How many weeks is she? 32. So overall the measurements are low. Fetal heart rate 145, but the abdominal circumference is 25 weeks, which means the head is a little bigger, the abdomen is smaller. What is this suggesting? Asymmetric IUGR. Now the amniotic fluid index is 7 centimeters. That's borderline. 5 to 8 is kind of borderline. Biophysical profile, 8 out of 8. That's without the NST. How do we do the AFI, the amniotic fluid? Imagine, if you would, that this is a mother's uterus. This is the umbilicus right here. We divide the uterus into 4 quadrants with a vertical and a transverse line through the umbilicus. So here's quadrant 1, quadrant 2, quadrant 3, quadrant 4. What is the deepest pocket, vertical pocket of amniotic fluid in each quadrant? We add those up, and we have the 4-quadrant AFI. And you see normal is 8 to 25. 5 to 8 is borderline. This is in centimeters. Less than 5 we call oligohydramnios, and over 25 is polyhydramnios. See, amniotic fluid comes from urine flow from the baby. That's where it's made. How is it removed? Swallowing. The fetal swallowing. So our concern is, if there isn't enough urine flow, because of decreased placental blood flow, decreased renal blood flow, decreased GFR, the baby's in trouble. So that's why we look at the amniotic fluid. So our assessment is asymmetric IUGR, chronic hypertension. This is my crude drawing of a normal fetal head and normal abdomen. And the two kinds of IUGR, we have asymmetric and we have symmetric IUGR. With asymmetric, the head is normal size, the abdomen is small. In symmetric, the head is small and the abdomen both are small. So we have a head sparing with asymmetric. Just kind of put this in your brain somewhere. Asymmetric is most likely a placental maternal problem. The symmetric is more likely to be a fetal problem. Fetal problems such as early First trimester infection, toxoplasmosis rubella cytomegalovirus. Chromosomal anomaly, your trisomy 21, trisomy 18, Turner syndrome. Or it could be some fetal anomaly. Fetuses that have congenital heart defects, neural tube defects, are smaller, symmetrically smaller. In this case, we're looking at asymmetric, more likely a placental blood flow problem. So, what are we going to do? We know the baby's small. We're going to follow for fetal well-being. We're going to do an NST. It's reactive. So the heart rate does go up with movements. Management. The treatment plan is serial NSTs, AFIs, biophysical profile to evaluate fetal well-being, and we're going to do this weekly. See, at 32 weeks, this baby is too early to deliver. We'll do serial ultrasounds and fundal heights to measure the fundal growth, so we're going to see her frequently for that. If there is evidence of fetal compromise, NST becomes non-reactive, amniotic fluid becomes low, biophysical profile is not reassuring, we will deliver. And at that point, we need to decide maybe a cesarean if the baby's not doing well versus a vaginal delivery. Any questions on IUGR? We've gone over the two kinds of IUGR. What is the etiology? What is the management? Let's say you have a symmetrical IUGR from a first trimester rubella infection. What's the management? I mean, you really can't do anything. It's already done. It's not a problem of the placental blood flow. See, the symmetric is basically just observation. The asymmetric is where you start doing the fetal testing. Okay, any questions? All right. Next topic. Case 10, painless late trimester bleeding. Painless late trimester bleeding. 30-year-old multigravid, 30 weeks by dates, comes to the emergency department with painless vaginal bleeding. What's the most common cause of painless late trimester bleeding? Placenta previa. What is an uncommon cause of third trimester painless bleeding? Vasoprevia. That's a whole different story. She awoke an hour ago with blood trickling down her legs, a pool of blood on her sheets, minimal uterine tightening, denies recent intercourse, good fetal movements, no prenatal care. First pregnancy, emergency low transverse cesarean section at term for breech presentation. So she had a previous cesarean, and now she's got bleeding. You need to think of uterine rupture. A uterine rupture, typically not painless, but at least that's a possibility. She smokes a pack a day. What's that associated with? Abruptio placenta. Occasional cocaine use. What's that associated with? Abruptio placenta. Vital signs stable. General exam is unremarkable. Uterus is soft, non-tender. See, what would you expect with an abruption? What would the uterus feel like? Tense and painful. So this, even though she's got risk factors for abruption, I'm thinking more of a previa. Fundal height, 28 centimeters. Is that okay for 30 weeks? Yeah, it's okay. Fetal heart tones, 135. What's normal fetal heart baseline rate? 110 to 160. So that's okay. Bright red blood is emerging from her introitus. Differential diagnosis, where we've got all of the causes of late trimester bleeding: placenta previa, abruptio placenta, bloody show, vasoprevia, uterine rupture, lower genital lesion. What's our working diagnosis? Got to be placenta previa. That's got to be the first thing you've got to rule out. How are we going to rule out placenta previa? Ultrasound. Obstetrical ultrasound. While we're doing the ultrasound, we can do a biophysical profile, right? Look for breathing movements, gross body motion, extremity tone. We'll get a CBC, see where we are in terms of her blood count, and a type and screen, because we may want to give her ROCAM. Ultrasound, intrauterine pregnancy, 30 weeks, so that's appropriate for dates. Transverse lie. Would that explain why the uterus measures a little bit less than you'd expect? Baby's laying transverse. Why is the baby transverse lying? It can't engage into the pelvis. Anytime you have on the exam a fetus is transverse lying, think of placenta previa. Baby is breech presentation, what should you think of? Uterine anomaly, like a septate uterus, diadelphous uterus, double uterus. See? But transverse lying, think of placenta previa. Complete previa. What does complete mean? Right over the cervix. Amniotic fluid is 11 centimeters. Is that okay? I'm happy with that. Biophysical profile, das ist gut, yeah? 10 out of 10. CBC, hemoglobin 9. What's normal lower limits of hemoglobin in pregnancy? 10. She's a little anemic. She looks anemic. Hematocrit 27. That's low. Platelets 210, so she doesn't have thrombocytopenia. Type and screen. We'll see where that goes. Okay. Assessment, placenta previa. The most common cause of painless third trimester bleeding. About 0.5% of patients at term will have placenta previa. So it's not really common, but in terms of painless bleeding, it is the most common cause. What's our management? We're going to start an IV, 16-gauge needle, isotonic fluids, type 1 cross-match, a couple of units of blood at least. We're going to place the Foley catheter to measure urine output, and we're going to see where things go. But do not perform a pelvic examination until you have done your ultrasound. And if you've done your ultrasound and you see a placenta previa, that's even more reason not to do a pelvic exam. Okay, further diagnostic plan, Kleihauer-Betke test. Why do you do Kleihauer-Betke test? For fetal maternal bleed. What's the pad count? You put a pad on her perineum and you weigh them, pads. We figure 1 milliliter of blood weighs 1 gram, and so you can figure out how much blood is being lost. Serial CBCs. The Kleihauer-Betke test is negative for fetal red blood cells. Pad count is 4 an hour, which is reasonable. Serial CBC shows hemoglobin is basically unchanged. All right. We're going to admit her to the maternity unit, and the management will depend on the subsequent hospital course. This would be a uterine rupture. This is typically catastrophic in terms of the mother's vital signs. Fetal heart tones are lost, and this is immediate laparotomy if the baby isn't already thrown out into the abdominal cavity. Now, this is a normal placental implantation, and you can see the placenta is up in the lateral wall or fundus of the uterus. You can have a marginal placenta previa where the placental edge is in the lower segment but not over the cervix. You can have a partial placenta previa where it's right to the cervical os but not over it. Or you can have a complete total central previa where it's right over the cervix. This patient here could potentially deliver vaginally if over time the lower part of the placenta will atrophy and the upper part will hypertrophy. A total central previa, this patient is going to require a cesarean. If she breaks open at, say, 34 weeks, hemorrhaging, you do an emergency cesarean. If she gets to 36 weeks, then we would probably just schedule a cesarean after doing an amniocentesis with LS ratio showing fetal lung maturity. So the management of placenta previa varies. In terms of abruption, you can have an overt abruption where blood leaks out and comes out of the cervix. Or you can have a concealed abruption where there is a clot of blood which is behind the placenta. And that never does show up. And this will vary as well. Let's say a patient comes in and she is term, she has abruptio placenta. Pain, full bleeding, fetal heart tones are normal, maternal vital signs are stable, and she's 9 centimeters dilated. She'll deliver vaginally in just a few minutes. But let's say that mother or fetus are unstable, any gestational age, cesarean. Okay. And vasoprevia is where you have a main part of the placenta and an accessory lobe which are joined by a vessel that runs over the cervix. And if that ruptures, the membranes rupture and that vessel ruptures, fetal blood. What's the management here? Crash, cesarean. You don't have time. I mean, this needs to be done within minutes or you can have a dead baby. So, third trimester bleeding varies depending on what your diagnosis is. This is a Claerhaut-Bethke test looking for fetal cells. Can you see the fetal cells? They are larger and they are more intense in their staining.